and meet with people on site visits, answer questions, and facilitate understanding of the program. The folks across the hall are the ones who actually process the application, and we're in close communication with them. So we think we provide a high level of customer service throughout the whole process. So keep that in mind, that we're always available to answer questions, to help you navigate through the process, and in a way be your allies in moving through the application. Our program, the Medicaid Incentive Payment Program, is a program within MEHI, Massachusetts eHealth Institute. And MEHI is part of something called the Mass Technology Collaborative, which is a nonprofit public economic development agency. So we are an affiliate of the state, so to speak. In terms of the various programs that MassTech runs, there are essentially three. One of them is the Innovation Center, and that is really, the Innovation Institute, which talks about developing business, supporting business, creating ideas that will create new business opportunities across the Commonwealth. The MBI is the Mass Broadband Institute, which is focused on extending broadband where it isn't, which is primarily Western Massachusetts and Southeastern. And then MEHI, the Massachusetts eHealth Institute, that's us. We're focused on leveraging the power of technology to improve healthcare. Some timelines that you should be aware of. Beginning in January, there's a requirement to be hooked up to the Health Information Exchange. That again is one of the programs that's run out of the Massachusetts eHealth Institute. The Regional Extension Center will be winding down in January, February. That program was focused on getting people from paper to certified electronic health records, and it's been very successful in doing so. The third item is the licensing requirement, which has been initiated by the Commonwealth of Massachusetts. January 2015, all physicians will be required to demonstrate proficiency at meaningful use. And the last item, all providers, all healthcare providers across the board are expected to have EHR's electronic health records interoperable, which means they'll be able to speak to other clinics, hospitals, other providers, and be connected to the Health Information Exchange. So that's an ambitious goal in January 2017, which goes far beyond the number of people who are eligible for the incentive payment program. Here are the very specific aspects of MEHI, how we can help. Our website, which we continue to develop, will provide numerous resources. For example, this webinar you will be able to find on there both the audio and visual part. MEHI Community, which is communities of practice. EHR, we've done a lot of work already, and we expect to do even more in the future in terms of the promotion of the certified electronic health records. And the highway, or last mile as it's called, which is really about the Health Information Exchange. In its simplest form, it's encrypted email, but it can obviously move well beyond that, where you're having direct linkages, exchanging medical records. And the last one, innovation, is where we take it to the next level, and we're really talking about creating an eHealth roundtable, which is a discussion at the high level, policy level, and then identifying and promoting innovation in technology so that the power of technology is leveraged to provide a higher quality of health care. The three programs currently in operation: Regional Extension Center, the Medicaid Incentive Payment Program, which we'll be focusing on today, and the Health Information Exchange. Now I'd like to turn it over to my colleague, Elizabeth Franczkowski, and we'll be switching off now and then so you don't get bored with either of our voices.
And we're also going to have a poll at the end to see whose voice you liked better. Just to give you a quick overview of the Mass Medicaid EHR Incentive Program and a little bit of an idea of some background and how we got here. The primary vision of the Medicaid incentive program is essentially to improve quality and coordination of care by connecting providers to patient information through the use of certified EHR technology. So it's really creating an interconnected network of providers, hospitals, clinics, and so forth to improve the quality and coordination of care. Our primary goal here is to promote the adoption and meaningful use of certified EHR technology, and that's really the key there, that in order to qualify for the incentive program and really to participate in the overall goal of the program, you must have certified EHR technology. And that is for both eligible professionals, who we affectionately call EPs, and eligible hospitals, which we refer to as EHs throughout the presentation. The Health Information Technology for Economic and Clinical Health Act, or HITECH, as is much easier to say, of 2009 was passed as a part of the American Recovery and Reinvestment Act, also known as the stimulus bill. And the HITECH portion of that act created financial incentives through Medicare and Medicaid who demonstrate meaningful use of federally certified EHR systems. And that's a really key term there, is the meaningful use. It's not enough just to have the technology. The incentives are really designed to motivate people to be meaningful users of the technology. And these incentive programs are run through both Medicare and Medicaid. Medicare is run at the federal level. Medicaid is a partnership between federal and state agencies. So here in Massachusetts, MassHealth and eHealth developed our SMHP, the State Medicaid HIT plan, HIT plan, to administer key components of the Medicaid EHR incentive program. The SMHP was approved in September 2011, and so we, as eHealth, really coordinate very closely with MassHealth as they plan and oversee and really direct the course of the Medicaid EHR incentive program, and we administer key components. Our program launched in October 2011, so we're relatively new. We're new kids on the block, and you know, we continue to learn and grow. And as Al said, we're here as a resource for providers. Our role in administering the program is really centered around program planning and administration, the enrollment and eligibility verification, you know, the payment authorization. All of those functions are handled by our provider enrollment team. As Al mentioned, they literally sit across the hall from us, and so we work very closely with them and work in close collaboration to assist providers and answer any questions that you have and work through any barriers you may have, any little glitches with your application process. We truly try to help and provide excellent customer service in terms of moving applications along. And the second bullet point there is my role and Al's role here, outreach and education. In terms of registration, you can see the total eligible professionals that have registered with the program is 5,757, and then it breaks it down by provider type. Physicians, by and large, you know, being the biggest group of providers who have so far registered and attested for the program. Dentists, certified midwives, nurse practitioners, and then total EHs registered at the end there was 60. And although it looks like a tiny number when it's on a bar graph like this, those eligible hospitals represent literally tens of thousands of providers. So we're getting there in terms of getting people registered and enrolled and receiving the payments. In terms of incentive amounts distributed, at the very top there you see the two terms AIU and MU. AIU is the first year of the Medicaid EHR incentive payment program, which is the year that requires you to adopt, implement, or upgrade your EHR technology. So in that first year, you don't have to demonstrate any meaningful use measures per se, but you just have to have the technology. And the meaningful use stages progress from there on. So as you can see, total hospital AIU payments and total EP AIU payments compared with the total MU payments. Al?
Okay, thank you, Liz. So what we're shooting for in this webinar is to talk about the important timelines, patient volume threshold, AIU, adopt, implement, upgrade, stage 1 and stage 2 of meaningful use, what sort of supporting documentation is required, the initial registration attestation process, that's when you're first signing up, how do you access the Massachusetts Immunization Information System. Because one of the key requirements of meaningful use is public health measures, and in Massachusetts that's the one that you want to be focused on, is submitting basically a test communication to the Massachusetts Immunization Information System. And as Stephen said, please be sure to ask questions. We'll save them for the end so that we won't run into a time problem in terms of covering the entire agenda, but we do hope to get to all of your questions. A couple of the timelines. The earliest you can submit your 2013 application is actually starting in a few weeks, by the end of June. Our system will be up and running, and you'll be able to attest in for the year 2013. Stage 1 changes are going into effect in 2013 and 14, and let me explain what that's all about. In August of 2012, the Stage 2 final rule was made public. In that, there were specific changes in Stage 1. So it wasn't just about introducing Stage 2. It actually went back and made some changes in Stage 1, which will be implemented over 2 years, some in 2013 and some in 2014. So it's important to realize which year you're submitting your application in as to what standards or measures you'll need to meet. I know it's a little more complicated, but I guess I just emphasize stay in communication with us so that we can inform you of those changes so that you know that you're going after the right measures in the right way. Stage 2 will begin in 2014. That doesn't mean that you will necessarily begin Stage 2, but for those who have completed 2 years of Stage 1, and there were some that got their initial payment in 2011, so in 12 and 13 they completed Stage 1, and so they would begin meeting Stage 2 meaningful use measures in 2014. Remember, that's the 4th payment year. So whatever your 4th payment year is, that's when Stage 2 takes effect for you. In terms of the Medicare Incentive Payment Program, 2014 is the last year you can become involved with that, and our program is 2016. So our program runs all the way through 2021. Part of a new act passed last summer, Chapter 224, requires that physicians will need to demonstrate meaningful use as a condition of licensure. The exact specifics of what that demonstration will look like are being developed, so it isn't clear at this point what that means. Obviously, if you've attested to our program in meaningful use, you would in fact meet that requirement. Medicare payment adjustments begin in 2015 for the hospitals and eligible professionals that are not meaningful users. AIU does not equal meaningful use. So that means the first year of our program does not, in fact, meet the meaningful use requirement. However, if you do meet the meaningful use requirement under Medicaid, that would exempt you from the payment adjustments with Medicare. And as I mentioned, 2016 is the last year to sign up for our program, with 2021 being the last year to receive payments. Here's a very quick comparison between the two programs. One of the key elements which just came up is the sequester does impact the Medicare program. It does not impact Medicaid. So there's a 2% reduction for as long as the sequester stays in effect. On the bottom left, you see a number of 44,000. Actually, the amount of payment begins decreasing this year. So if you applied for the first year in 2013, the maximum you could receive is 39,000. In Medicaid, again, the last box on the right, the total payment is $63,750, and that doesn't change. So as long as you submit applications and receive the green light for each year, all 6 years, you would receive the full payment of $63,750. Here's a graphic just showing you the progression of the process going from adopting the certified EHR technology to beginning to use it in an effective, meaningful way. Stage 1 is really about functionality. Does your EHR function? Does it work? Have you integrated it into your practice? Stage 2 basically takes it to the next level where you're actually using it at a much more robust level. You're beginning to report to public health agencies. You're beginning to communicate with other clinics and hospitals. Stage 3 is really beginning to say, okay, what has this really done in terms of improved outcomes? Is patient care improved? Are we getting measurable, tangible results in improved outcomes? There will be additional stages. We don't know exactly what that will look like. But in terms of the years, year 1, payment year 1 is the adopt, implement, upgrade. Payment years 2 and 3 are stage 1. 4 and 5 are stage 2. And payment year 6 is stage 3. Here's an idea of the different reporting periods. For the first year, if you're doing the adopt, implement, upgrade, the only reporting period is to demonstrate patient volume threshold, which is a 90-day reporting period in the previous calendar year or in the previous 12 months to when you're testing. So that requirement remains through every payment year. So all 6 payment years, you have to demonstrate that you're serving the target population. The column on the far right, EHR reporting period, is actually where you're capturing your meaningful use data in the current calendar year. So stage 1, the first year is 90 days, and then every year after that it's 365. However, there's an exception in 2014 because the Office of the National Coordinator has required all systems to be certified to a new standard, and allowing that may take some time to implement and migrate information. The requirement for 2014, no matter what stage you're in, is for a 90-day reporting period. So keep in mind 2 different reporting periods, patient volume threshold and EHR reporting period. And we'll help you with that if you have confusion about that or don't quite understand how they work. Please don't struggle. Just give us a call. We can walk you through it. Here's the picture of the payments. First year is $21,250. Each subsequent year, $8,500. Pediatricians can come in meeting basically a 20% Medicaid patient volume threshold. However, then the payment is reduced to $42,500. If the pediatrician does meet the 30% threshold, you receive the full incentive payment amount of $63,750. Okay, time for Liz. Fire away.
So just to give you an idea of the eligibility requirements for eligible professionals, there are 4 major requirements here. The first one being, as I mentioned before, that your EHR technology must be certified by the ONC, which is the Office of the National Coordinator for Health Information Technology, ONC for short. And the second criteria there just gives you an idea of the eligible provider types. You can see that residents have recently been added. With residents who wish to apply for the program or organizations who wish to apply on behalf of their residents, there is an additional verification process that we must go through in order to determine point 3 there, the third requirement, that 90% or more of their services are not furnished in a hospital setting. With any other provider, we can usually determine that through billing records. However, because residents don't typically bill on their own, they bill through their attending, we do have to have an alternate methodology to determine that third requirement there. So it is a little bit more in terms of the application process for residents, a little bit more rigorous, but they have been added, and the other provider types are listed there as well. Again, for that third requirement, it just requires that 90% or more of a provider's services are not furnished in POS 21 or POS 23, just determining that we're not we're not allowing hospitalists to participate in the program, but rather, providers who provide care in an outpatient setting. For the fourth point there, each provider must demonstrate that at least 30% of their patient volume is Medicaid or Medicaid 1115 waiver population, and that's really to ensure that the incentive payments are being made to providers who provide services to the target population of the program. As you can see there, the new addition to that requirement is that your 90-day period for determining your patient volume threshold can be either from the previous calendar year or from the 12-month period leading up to your attestation. So that's a new option for providers and for groups to determine their patient volume threshold, which allows you to use a 90-day period actually in the current calendar year. And just as a point of clarification, something that was mentioned before, providers can actually register now for program year 2013. The MAPR system is ready to accept applications, so providers are able to attest now for program year 2013. And we do encourage providers to register early, attest early, just in case there are any potential glitches with your application, or if there's any supporting documentation that may be needed. It's best to get your application in as soon as you're ready. Another big change here is that for the fourth requirement there, the 30% Medicaid patient volume, providers can include zero paid and denied claims. So it doesn't have to be a Medicaid MassHealth paid claim. It can also include zero paid and denied claims, as long as the provider and the patient were both eligible on the date of service. Again, just a listing of the eligible provider types. Please note that pediatricians must be board certified in pediatrics in order to qualify for that 20% patient volume threshold requirement. When you're calculating your Medicaid patient volume threshold, you can include both Medicaid fee-for-service and Medicaid MCO encounters. The listing here is not a comprehensive list of all of the plans that can be included when you're calculating your patient volume threshold. We have a complete listing on the reference that we refer to as our Medicaid 1115 waiver population grid, which is something that is available on our website, or we will be happy to email to you after this webinar today, in case that's a resource that you don't already have. It is important to have that to reference when you're calculating your patient volume threshold. Al?
Thank you, Liz. Registration and attestation. Those two terms translate into signing up with CMS. So the very first step is making sure that the individual provider is recognized with a NPI and recognized with a MassHealth provider number. So there are basically 3 steps to completing registration and attestation. The first one, the box on the left, is at the CMS level. So again, either if you went for Medicare or Medicaid, everybody starts at the same point at the CMS website. Registration and attestation has to do with the eligible professional. The identity and access, INA, has to do with the designee. So if you have an individual in the practice who is actually going to be doing the application on behalf of one or more of the eligible professionals, that individual has to be identified and also has to be given access to represent the individual professional. Once that stage is completed successfully, it then moves on to the middle stage, which is the MassHealth Provider Online Service Center. Essentially, that's a what am I trying to say? Turnstile, which then moves you on to the actual application, which is known as MAPR. That's the online application, and that's which our team actually processes your application, where you submit the data, and after the process is completed, we then make a recommendation to MassHealth to release the payment. That is completed once the individual provider is checked against any censures, either on the state or federal level. Here are the specific steps. The first one, again, is really about making sure all the numbers match, the service location, spelling of the name. believe it or not, the spelling of the name is actually a big deal. So if the middle name is included or it's not included, or if there's a hyphen, or if an individual is married, all of those will cause a mismatch in the identifying numbers and name. So it's very, very important that everything align. If you do run into any problems with that, please feel free to call our support team, and they'll help you work through any discrepancies that you may encounter. Step 2 is really where you're designating an individual to do the application. And so 2 and 3 are really about making sure that the designee is in fact confirmed by the eligible professional. That's a very important piece. Step 4, the eligible professional or the designee completes the application. Step 5, if it's done successfully, you get a green light to move on to the mapper application stage. And step 6 is where you actually engage in completing the application in mapper. Now Liz is going to go on to explain the various ways you can approach patient volume threshold, because there are a number of ways to do that, and you should be aware of all of your options so that you take advantage of the one that best serves your needs. Liz?
So thank you, Al. So to give you some specifics about calculating patient volume threshold, as I mentioned before, there are now two fundamental options in terms of defining your Medicaid population. The first being that you would define your population by Medicaid paid encounters, where an encounter is defined as one service per day per patient, where Medicaid or a Medicaid 1115 waiver population, that listing that we referred to before, paid for all or part of the service. So again, that would just be based off of paid claims. On the right-hand side there, in the Medicaid enrollee definition, it would be any service rendered to a Medicaid or a Medicaid 1115 waiver enrolled individual. So that would include zero pay and denied claims, again, provided that the provider and the patient were both eligible for MassHealth on the date of service. This slide gives you the actual math of determining your patient volume threshold percentage. So if you're using the paid approach, obviously you would have your Medicaid paid encounters over your total paid encounters. And on the bottom right there, you can see the CHIP reduction factor referenced. And the CHIP factor for 2013 is to be determined. We don't have that exact percentage yet. Usually the CHIP factor in previous years has hovered around 3%, 2.9, 3.1. It's hovered somewhere around 3%. And basically it's used to reduce the patient volume threshold by an average number of CHIP encounters. Because those can't be singled out in an easy way, and they cannot be included in your calculation for purposes of the Medicaid EHR incentives, MassHealth takes an average of providers across the state, and then every provider must reduce their patient volume threshold by that percentage. For the enrollee approach, same math, you would just use your Medicaid enrollees over your total enrollees, and again, the CHIP factor would need to be taken out, subtracted from your total patient volume threshold. There are three primary ways to achieve patient volume thresholds: individual, group proxy, or practitioner panel. We'll start with the individual approach. The two options that the slide is referencing there are the paid versus enrolled, which we've covered. So this slide gives you an example of a provider who would not meet the 30% Medicaid patient volume using paid encounters, but by bundling together all of the Medicaid enrolled encounters, the provider does meet the 30% patient volume threshold and can participate in the program. So sometimes it's to a provider's advantage to include the enrolled enrollee Medicaid patients. Sometimes it does create an additional administrative burden, so if you can meet it just using the paid encounters and that's an easier way for you to calculate your patient volume threshold, then you can always go that route as well. This slide gives you an idea of a provider who practices at multiple locations where he or she achieves the patient volume threshold at one location but not at the other. And as you can see, this is using the paid encounters, but the asterisk at the top there lets you know that obviously you could use the same concept for the Medicaid enrolled approach. Calculating needy individual patient volume for FQHCs, federally qualified community health centers. Again, two options. The difference with the federally qualified health centers, FQHCs, or RHCs, rural health centers, is that they use a target population of what they call needy individuals. Essentially, we're talking about the same target population, and it includes Medicaid and Medicaid 1115 waiver population, but you can also include, or you should also include, uncompensated care and any no-cost or reduced-cost services provided on a sliding scale. So in order to use this definition, the provider must practice predominantly at the FQHC or RHC, which means that 50% or more of their encounters over a 6-month period in the current calendar year occurred at that location. Again, the same basic math here that you will be using your needy individual paid encounters over your total paid encounters, or your enrolled needy individual encounters over your total patient encounters. For professionals that have practiced for less than 6 months in the current calendar year at the FQHC or RHC, they can still participate in the program. However, they have to follow the following criteria: that the FQHC RHC must use the group proxy method to determine patient volume, which the group proxy method is something we're going to go into next. And they must calculate the Medicaid patient volume threshold, the standard way of calculating the threshold, as opposed to the needy individual patient volume threshold. And because they're doing that, they must reduce their percentage by the CHIP factor. For group proxy, a group is defined as 2 or more EPs who are practicing at the same site. So this is where you would roll everybody's Medicaid encounters into one calculation. It's less administrative burden for most organizations and most practices. It's the most inclusive option, meaning that if you have an individual provider who would not meet the 30% patient volume threshold on their own, but by including them in the group proxy, they would meet it, that's obviously to your advantage to use this methodology. And it also provides for easy, quick validation on our end. So it really is less administrative burden on both sides in most cases. For using the group proxy, there are just a couple requirements. There must be an auditable data source to support the patient volume determination. All the professionals in that organization must use the same methodology in any given year. So you can't have one provider who is attesting using individual patient volume threshold calculations and then everybody else applying as a group. They have to decide one way or the other. However, you can switch from year to year. So in any given year, everybody has to use the same methodology. But from year to year, if for some reason it's to your advantage to switch from individual to group and back and forth, you can actually do that from year to year. Just of note there, if your institution or organization has unique billing practices and it's difficult for you to figure out exactly how to calculate the group proxy method and what to call a group. In other words, if you have multiple locations and do you break your groups down by specialty or by location, by address, please talk with our enrollment team because they can help you determine the best way to calculate your group proxy patient volume threshold and then have it be validated by our team. This just gives you an example of using the group proxy method and how it can help boost providers who may not meet the individual patient volume thresholds. So as you can see, the third individual there, the nurse practitioner, is only at a 10% patient volume threshold on his or her own, being 30 over 300. But including the nutritionist, who is not eligible for the program but does see Medicaid patients, mass health patients, their total group proxy patient volume threshold is 38.75, allowing all of the eligible professionals in that list to participate. Similar math here, using the enrolled approach and getting that nurse practitioner, up to a point where he or she is eligible to to participate in the program and receive the incentives by using the entire group's data, even those professionals who may not be eligible for the program in and of themselves. For practitioner panel, we define it here as being for eligible professionals who practice in a managed care or medical home setting, and that's pretty much how it's been used thus far, but we do recognize that the landscape of healthcare is shifting dramatically and will continue to shift dramatically probably over the next several years with ICOs, ACOs, global billing, capitated payments, that sort of thing. So the landscape of healthcare, I think, is shifting quite a bit, and this practitioner panel may be a useful option for many practices as you move toward a more global billing environment or something of that nature. So practitioner panel, broken down pretty simply, is you would include any patients that are assigned to a practitioner's panel. In addition to that, any unduplicated encounters that that practitioner had with Medicaid patients who were not assigned to his or her panel. So the math works out like this. You have 250 patients assigned to that particular practitioner's panel that had at least one Medicaid encounter in the 24 months prior to the beginning of the 90-day period. So you want to make sure that they have been seen within the last couple of years. You add to that any unduplicated encounters with Medicaid patients that do not happen to be on that practitioner's particular panel, and then divide that by the total patients assigned to the panel over the total unduplicated encounters, and you come up with the 46% patient volume threshold. Just of note, the patient volume threshold is required for each phase of the program, which includes AIU, the first year's payments, and each stage of meaningful use thereafter. As Al mentioned before, the patient volume threshold and EHR reporting period are two separate reporting periods, which is important to keep in mind. And then because of that new option that allows you to choose a patient volume threshold reporting period from either the previous calendar year or the 12-month period leading up to your attestation, in theory you could have a patient volume threshold reporting period and an EHR reporting period overlap. However, this is not allowed under the rules of the program. Our operations staff, our enrollment team, are required to request supporting documentation whenever there is a variance of plus or minus 25% between what you report on your MAPR application and what we're able to determine from reviewing the MassHealth data warehouse claim files. And the types of documentation we may request, you can see listed there. And according to state guidelines, professionals and organizations are required to keep their supporting documentation for a minimum of 6 years for auditing purposes. And just a real quick note here that we do what's called pre-validation here. So it may seem like we're kind of being naggy and asking for a lot, asking for a lot of supporting documentation and asking for you to go back and forth and provide us with a lot of detail. But that's really for your benefit and for ours. It's really a protective mechanism where in the event of an audit, we would have all of our ducks in a row as you would as well, so that when audit time does roll around, you have all of your supporting documentation in order, as would we. For Adopt, Implement, and Upgrade, again, this is the first year of the program. Very simply put, you just need to have an EHR that is certified. Here's the supporting documentation you would need to provide in order to prove that to us. Any one of the first three there, proof of purchase or vendor contract, and then a letter from your CIO or IS department giving us the details about the providers who will be using the technology, the locations where they'll use it, and so forth, as well as the ONC certified product list number, which can be found at the website below. For an overview of meaningful use, I'm going to turn it over to Al.
Okay, thank you, Liz. Meaningful use should be looked upon really in two different ways. One are the specific measures and requirements that are necessary to receive an incentive payment. But the larger definition of meaningful use has to do with leveraging technology to improve patient care, patient outcomes, reporting to public health agencies. In other words, meaningful use is a qualitative advance in the provision of healthcare. So it's important to keep that in mind, that it isn't simply meeting a list of specific discrete measures. It really all adds up to something more than the sum of the parts. And that's an important aspect to really capture the benefits for your practice. So it isn't just a matter of meeting requirements for the incentive payments, but leveraging technology to improve your practice and to achieve superior patient outcomes. Here are the sort of the philosophical pillars of meaningful use: improve the quality, safety, efficiency, reduce health disparities, engage patients and their families in their health care. This is a big change, and technology can play a very significant role. For example, the advent of patient portals, where individuals have access to their health information in a more complete fashion than what they have in the past. The third one, improved care coordination, is already reaping results. For example, with medication, information being shared among different specialists, there's not duplication, more accuracy in the prescriptions, and ways of checking against allergies or drug-to-drug problems that may arise. So care coordination is going to continue to be a major, major benefit of the meaningful use process. Population and public health. This is really focused on getting more immediate information to public health agencies, so any issues that are of a public nature can be addressed sooner rather than later. The last one, of course, is a top priority for everyone: privacy and security. So it isn't just a matter of confidentiality, but it's also a security issue with the entire system. Stages 1, 2, and 3. 1 is, again, about functionality and your ability to use the system. And it's beginning to set the stage for information sharing. Stage 2, where there is a very, very active information sharing, not only with the patients, but also with other practices, specialists, and so forth. Stage 3 is focused on demonstrating improved outcomes. So keep in mind that once you have this all set up and once it's rolling and everybody is using this technology, we're really looking to document in a very scientific way the improvement of outcomes as a result. Here's a quick overview of the different stages. As I mentioned, stage 1 is really about making sure the system works, that your team is actually using it properly, and that you're beginning to integrate it into your clinical practice. Stage 2 is taking it to the next higher level where the thresholds are higher. You're using it for more of your patients, and the health information exchange becomes a much more critical part of how you're using your certified EHR technology. And then stage 3, we are actually beginning to basically get outcomes that would not be possible without the electronic health records and the health information exchange. So I'm going to touch upon some of the changes that have been introduced in the last year as a result of the stage 2 final rule. For meaningful use stage 1, there are 24 stage 1 meaningful use objectives, 14 required core, 5 objectives from a list of 10 in the menu, and then 6 total clinical quality measures, 3 core or alternative, and then 3 from a list of 38. And it is necessary to provide supporting documentation for some of the specific measures. A couple of the changes, the computerized provider order entry, an alternative way of computing it rather than unique patients is to use the total number of medication orders. And then in vital signs, there's a number of different options that can be used now in terms of selecting which one is appropriate for your particular practice. And again, we're always available to go into detail with these and work with you to see which one matches up with your practice and is the most appropriate. A couple of objectives have been dropped. Clinical quality measures, and that was basically to make sure that the computer had that capability. Starting next year, everyone will be submitting clinical quality measures to the state. Electronic transmission of key clinical information was dropped because that requires the HIE, which is not fully operational. The prescribing requirement, basically there's an allowance. If you do not have a pharmacy within 10 miles, you can take an exclusion from that. There will be, in 2014, you will have to answer menu objectives you can answer. Currently, you can take an exclusion, and that would count, but if you can, in fact, answer a menu objective, you have to do that. I'll just touch on these. The meaningful use general requirements, essentially, you have to demonstrate half of the eligible professionals encounters occur at a location that utilizes the certified technology. At least 80% of unique patients must have their data in the certified technology during the chosen 90-day reporting period. Measures 3, 5, and 7 use the same denominator as the 80% unique patients. So the unique patients you're going to be using in some of the measures. The encounters are calculated the same way as you do for patient volume threshold. These are just different formulations. I'm going to kind of move through these quickly, essentially showing different scenarios where you calculate whether or not an individual meets the general requirements. This is an example, I'll use this one, where you will have different individuals in the practice at different stages in the process. And it becomes a little bit tricky in terms of your own management of where is an individual, what year are they in. Now Mapper does retain that, so no matter what year you're in, you're coming back to the same application, and it will tell you where a particular individual is in the process, what payment year 1, 2, or 3. As you can see, all of these individuals do pass the 90% inpatient test, and one person does not meet the meaningful use requirements and therefore can skip a year. That's one of the benefits of this particular program. Supporting documentation, the immunization test, you have to demonstrate that the test has been made and that you have received an email back from the Department of Public Health called an ACK or acknowledgement email. We need to have that. The only reason you can avoid that or take an exclusion is if your particular technology does not have the capability to connect. Description of a clinical decision support rule that was implemented. This is very important. You need to identify what was that particular clinical decision support rule for that particular individual. Now remember, this is an individual application, so you have to have that for each individual application. Provide a copy of the security risk analysis report, and what we're looking for, a security risk analysis is not a full-blown HIPAA overview. It really is about the security of the EHR technology. So what we're looking for is what was the outcome of that report and what particular changes needed to be instituted and were in order to come into compliance. The last one, the EHR log audit, demonstrates that, for example, the clinical decision support mechanism was in the on position for the entire reporting period. So that demonstrates that you were, functioning and all the different aspects, the different measures were being recorded for the entire reporting period. Now we're going to just go into a little bit of the Mapper application thing just to give you a flavor for what that looks like and what are the different components that you need to be aware of. Liz?
In the interest of time and having a few minutes to take any questions that the audience members may have, I am going to go through this rather quickly, but basically what this shows you are some screenshots of what Mapper actually looks like. And again, this presentation and these slides will be made available online after this webinar, probably sometime within the next couple of days. So I am going to breeze through, but it basically gives you a screenshot of Mapper, shows where you enter your numerators, your denominators. At the bottom there, you click Save and Continue. It moves you on to the next objective. This here gives you a listing of the core and menu municipal use measures, which you can find at the CMS website. And the cool thing about this is that those are actually hyperlinks there. It's difficult to see on the slide, but those blue lines there are actually hyperlinks that you can click and drill down into more detail on each of the measures if you have specific questions. Obviously, some core menu objectives are not applicable to certain providers' clinical practice. So in that case, providers can claim exclusions. Some CQMs may not be able to be met during the reporting period chosen. So reporting zeros is acceptable for CQMs if that's what's been calculated by your certified EHR technology. Breeze through the MIIS slides, which again you can reference after the webinar. This does give you some information about the HL7 2.51 versus 2.31. You can only claim the exclusion, and Al, correct me if I'm wrong here, you can only claim the exclusion on the measure that refers to these if you have the 2.3.1. If you have 2.5.1 for HL7, you are required to submit that test message to the immunization registry. A little contact information there for the folks who run this particular part of the program and have all the answers about all the tech stuff. There's the help desk info. And speaking of questions, if you have any questions, we'd be happy to take them now.
All right. Our first question is from Cecilia Reese. Cecilia, you are now unmuted. Go ahead and ask your question. All right. Let's move on. I guess. All right. 1 second. Our next question is from Marie Voltaire. Marie, you are now unmuted.
Hi, Marie Voltaire from Lower General Hospitals. My question is regarding the public health objectives, and I don't know the process as to how the physician will start the immunization and how they will submit. I understand the process as far as the technology that we are using, but I am not sure how they need to contact the state and what else is needed for them to establish that communication to be able to transmit their immunization information.
Okay, the way it works, it's really about the technology connecting. That's the main focus of this. So depending if you have multiple sites, each site must send a test message. So it's essentially an email sent to the public health department. And again, you have to have that particular HL7 2.5.1. If your technology does not have that, and that's something you want to check with your vendor, if it does not have the 2.5.1, it has a 2.3.1, you can take an exclusion. However, if it does have the 2.5.1, then it's location specific. So if you have 3 or 4 or more providers at one location, one test would serve for all the providers at that location. So you don't have to do a separate test for each provider. It really is about the location. Even if you have a common server, in other words, that your test messages are still going through one common server, the requirement is you still must send a test message from the specific site. So the idea really is to ascertain that all the providers have the ability to submit information to the immunization registry no matter where they're located within your system.
Okay, I guess I understand. I will need to, I know we do have the HL7 2.51, so I'll need to figure out the rest of the information and see how we need to connect to the state and send that test file. Thank you.
You're welcome.
Great. Let's go back to Cecilia and see if she's on. Cecilia, you are off mute.
Cecilia?
Okay, we have no further questions. Is there anyone else out there who would like to raise a question? Because we have space to answer a question if you have one.
If there aren't any further questions, I would just like to throw out there that we're open to suggestions in terms of future webinar topics. So if there's a specific topic covered here or something we haven't covered here that you would like more detail on, please feel free to email Al and myself or contact any one of us here at MeHi to suggest a future topic for a future webinar. We really do want to reach out and provide you with the information that's going to be most useful to you. And in addition to that, just a reminder that Al and I do provide site visits. So if you would like one of us to come out to talk to your practice or your organization face-to-face, we'd be happy to do that.
We have one additional question. Scott Schroeder, you are unmuted.
Scott?
Yeah, I can.
Okay, if there are no further questions, I think we'll wrap up for today. Thank you so much for your attendance and your attention.
Thank you very much for attending. And again, we're here to help you and facilitate your success.